Okay, good morning, everyone. I'm Lori Lowell. I'm the Executive Director of Home Haven, and this is a program brought to you by the Home Haven Health and Wellness Committee. And our chair is Pat Allen. Pat is here, and I'm going to immediately turn it over to Pat, who will give you the name of the program and introduce our speaker. So again, thank you, Pat, for all the work of your committee, and take it away.
Well, thank you, Lori, and thank you, Dr. Miner, for being here with us. Dr. Miner initially reached out through the Adler Center looking for the opportunity to present her research and her understanding about sleep in older adults. And so we have finally been able to find a time that was mutually convenient for all of us. So this is great. I'm very pleased that she has agreed and is interested in working with us. So Dr. Miner is a geriatrician and sleep medicine physician at Yale University School of Medicine. After receiving her MD from State University of New York Downstate Medical Center, she completed further training at Yale University, including residency in internal medicine, a year as chief resident, a clinical and research fellowship in geriatrics, and a clinical fellowship in sleep medicine. That's a lot of education. That's made you very well prepared for what we're going to talk about today. She is past recipient of the National Institute of Aging GemStar Award and currently a Beeson K76 awardee. Her research interests include improving the evaluation and management of sleep deficiency in older persons. And recently, she has taken on a leadership role in the School of Medicine Diversity, Equity, and Inclusion program, which is certainly a key activity for all of the university. Dr. Miner has active research going on, and Dr. Miner, I'd like to let you know that this is a group that often is interested in participating in research. We recognize the importance of research and often are willing to participate when we believe it will benefit people in our age group. So we're looking forward to hearing about your research and letting us know if there's anything that we can do to assist in it. So without further ado, Dr. Miner, thank you so much for being here.
All right. Well, thank you for having me. And I'm always so happy to share this topic. I think knowledge is power. As you've heard, I've done a lot of educating of myself, and I never want to stop learning. And so I hope what I'm going to do is to teach you all a lot about sleep. And, interestingly, when I was in medical school and residency, I don't think I learned really anything about sleep. It was only that, I became interested in it in my care of older people because sleep problems are so prevalent. And that is what, made me decide to do a sleep fellowship. And so I hope to share some things with you to teach you about sleep. And also, as mentioned before, I'm happy to take questions at any point. I mean, I think this is for all of you. I have a set of slides. I don't have to get through all of them. And so, I really want to take the opportunity to have a discussion if we can and, go from there. So having said that, I'll go ahead through what, I thought the objectives of the talk should be today, to talk about why we sleep, what is normal for us to expect as we get older, what factors may disturb sleep as we get older, what can we do to improve that, and when should you talk to your doctor if you're concerned about your sleep. So let's start with the first one. Why do we sleep? So here is a little bit of teaching that I'm going to share from my time as a sleep medicine fellow. And this is one particular model, and I think probably the best model that explains to us not only how we sleep at night, but how we maintain weight during the day, how those things are controlled. This is the two-process model, and the two processes that we're referring to are a circadian process and a homeostatic process. And these two processes work together and sometimes oppose each other to help us maintain weight during the day and to maintain sleep at night. So let me go through those a little bit for you. So first, I'm just going to minimize this a little bit for a second. What allows us to maintain wakefulness during the first part of the day? Well, we're awake because hopefully we slept all night, and that means our homeostatic drive for sleep, which you see across the top of the slide here. So when we first wake up in the morning, we've slept well, so hopefully our homeostatic sleep drive is low. And then in the second part of the day, you can see that homeostatic sleep drive is increasing. And I'm going to come back to this when I talk about napping, and in certain times the importance of avoiding napping. So when you nap, you dissipate this homeostatic sleep drive, but we want that to increase during the day to help you fall asleep at night. But so during the second part of the day, this is where the circadian process, that circadian alerting signal, becomes important. We're awake in the second part of the day because that alerting signal is high and it's opposing that homeostatic process. So then in the first part of the night, we sleep because we've been awake all day, right? So that homeostatic sleep drive has been piling up during the day, and that allows us to fall asleep. But then in the second part of the night, as that's dissipating, you can see the circadian alerting signal is low. So that's what allows us to maintain sleep. You also see something you all are probably familiar with, melatonin. Melatonin is released, we talk about a dim light melatonin onset. That's the sort of cue to our brain to start releasing melatonin. And that is also really higher in the evening while we're sleeping. And so that becomes a very important part of our sleep-wake cycle as well. So that is how we sleep. The next thing I want to talk about is why we sleep. And this is actually, I think, a really exciting area of research that we're learning more about all the time. The fact is, sleep actually has a lot of different functions. So we know it's important for metabolism, for example. If there are problems with sleep, that can increase risk of diabetes, for example, and obesity. We know that sleep is important for immune function. So there have been some interesting studies, I think, especially around COVID, that people who got the COVID vaccine after being sleep deprived did not have as good an immune response as those people who had more quality sleep. Sleep is important for waste removal. And, frankly, because I'm interested in studying that connection between sleep and cognition, this is an area that's very interesting for me, that we're learning more about all the time. And what we're finding is that during particular stages of sleep, waste products are removed from the brain. And that includes proteins that, if they're otherwise allowed to deposit, increase your risk for Alzheimer's disease. So there really is a pretty direct connection that we're learning more about that connects poor sleep with Alzheimer's disease. So sleep is important for memory, and particular stages of sleep help us with our consolidation of memories. And this is a really interesting area too, physical performance. And so what I'd like to talk about here is that the NBA has actually become very interested in this, right? Because they have players that are with these crazy schedules, flying across the country, changing time zones. And the NBA has realized that their athletes don't perform as well if they're sleep deprived. So they are becoming very interested in how do you improve sleep in athletes to improve their performance. All right, so next I want to talk about what are some normal changes, okay? That these are ways that our sleep may change that have nothing to do with disease or other problems. This is just a normal process of aging. And so I want to start first by taking you through what we consider to be an appropriate sleep duration or amount of sleep at night. And so, those of you who went through the process of having children, or perhaps looking at what happens with your grandchildren, in younger years, we need a lot more sleep, right? So, it's sort of really interesting to think, because as a mother myself, I never felt like my newborn was sleeping that much, but they might sleep as long as 18 to 19 hours a day. Just unfortunately not in very consolidated parts. And so then as we get older, that sleep duration, that recommendation, it does change. So if we look out here and we focus on this sort of, if you can see this color, this darker blue, that's the sweet spot. Okay. So we think around 7 to 9 hours. And if you look here on the end at people 65 and older, that sweet spot is 7 to 8 hours. So I meet a lot of my patients say, oh, well, I'm older, I don't need to sleep as much. And it turns out that's not exactly true. So this is based on the fact that people who sleep in that sweet spot 7 to 8 hours report better cognitive health, better physical health, better well-being. So that's where these recommendations come from. But we do also have to recognize that 9 hours on the one end or 5 to 6 hours on the other end may also be appropriate. So there are genetic reasons why we have different needs in terms of sleep duration. So we do have to keep that in mind, but 7 to 8 hours is the sweet spot. The other thing that changes as we get older is sleep architecture. So this is, again, where I'm getting a little bit technical. I'm bringing you back into that sleep fellowship, just to do a little bit of teaching of what sleep looks like. So first, I want to focus on what sleep looks like in a younger adult. And so here you have the different stages of sleep. We start with wake on the top here. This is called a sleep histogram, by the way. So wake is at the top. Here's REM sleep, which is your rapid eye movement or dream sleep. And then we have the lighter stages, N1, N2. And then down here we have N3, or what we also call slow wave sleep. So this is sort of your deepest, most restorative sleep. And then what you can see here along this axis is time. All right. So if we're looking overnight, what we see generally happens. Oops, sorry about that. We start and wake, and then we fall asleep, and we tend to go into lighter stages, then deeper stages. And then about 90 minutes into sleep, we have that first REM period that you see up here. This is in red. And you can see it's a pretty short period. That ends, and then there's more cycling through lighter, then deeper, then more REM. And so then when we get towards the end of the night, we're really cycling between REM and lighter stages of sleep. And then what you see here, this is an arousal. Okay, so REM often ends with an arousal, but it's usually short and we go right back to sleep. Sometimes we're aware of that arousal, sometimes we're not. But I like to show this to say, sleep is not an 8-hour coma, right? We're cycling through different stages. It's normal to have arousals from sleep. So now that I've shown you the younger adult, I want to show you a typical example for an older adult. So we're thinking, 60s, 70s later on. And what you'll notice is many more arousals from sleep, these little spikes towards the top. And so that sleep architecture is not as regular anymore. And there's a bit of a shift towards lighter stages, those N1, N2, and a little bit of a shift away from the slow wave sleep and REM sleep. So that's sort of, your sleep architecture or your quality. What do the different stages of sleep look like? And then the other thing that might change as we get older is the timing of sleep. And so what I'm showing you here now, you see melatonin levels. And I want to start with this blue, or what we might call the usual sleep phase. And again, I want to bring up that idea of dim light melatonin onset. So perhaps around 8 o'clock at night, your brain starts to release melatonin, it peaks overnight, and then it dissipates. So what is very common as we get older is to have a shift towards an earlier sleep phase. And again, this is a normal thing that can happen as we get older. And what that means is that we start to release melatonin at an earlier time in the evening, which means we might go to bed earlier, but then that also means we probably wake up earlier, right? So if we go to bed at 7:30, we're not going to wake up at 8 a.m., right? That's way too much sleep, right? That's, 12 and a half hours of sleep. But I understand that, not everybody wants to wake up at 3:30 or 4:30 in the morning. I would just say, what you want to think about is, are you having an appropriate amount of sleep? And so although that 4 a.m. wake up call may not be pleasant, it may be normal. All right, so next I want to talk about factors that may disturb your sleep. And so here's a little bit of some of the earlier work that I've done looking at how sleep symptoms are common and multifactorial in older adults. And so I'll tell you a little bit what I mean by that. So I'll start with this one. Oops, sorry, don't know what's happening with my slides here. Okay, here we go. So the first symptom that I looked at is the symptom of insomnia. So this is trouble falling asleep, trouble staying asleep, or early morning awakenings that are causing an impairment in your ability to function during the day. And so this is data collected from older adults living in New Haven. So people just like yourselves. And so what I found was that probably about 40% of older adults, and the average age here was 84, 40% of older adults experience the symptom of insomnia. And so when I'm saying that also this symptom is multifactorial, these are all of the things that I found that were strongly associated with that symptom of insomnia, inability to sleep at night. So interestingly, but not surprisingly, people who have a lot of daytime sleepiness might have insomnia or trouble sleeping at night, which, if you remember back to the two-process model, makes sense, right? If you're sleeping during the day, you're dissipating that homeostatic drive, and you don't have as much sleep pressure or drive to sleep when you're trying to sleep at night. Depression is also very closely related to insomnia. Sleep disorders, and I'm going to talk about these specifically in a few slides. These are things like sleep apnea or restless leg syndrome are commonly associated with insomnia, and then medication use. So this is also another point that I'll come back to. So similarly, I looked at the symptom of daytime sleepiness. So feeling the need to sleep, or even feeling this desire to doze during the day. This is what we mean by daytime sleepiness. You can sort of think about it as almost the reverse of insomnia, although both things could be related. So too much sleepiness. And what we found in these older adults in New Haven is that they were much more likely to have low levels of physical activity, also to have depression, sleep disorders, and medications. Okay, so let's talk about that medication piece. The fact is, as we get older, we tend to collect medications, and these can disrupt our sleep in many ways. And so I want to go through that a little more specifically. So let's talk first about daytime drowsiness or daytime sleepiness. Here are just a few examples of medications that might cause that. If you take an antihistamine like Benadryl, or if you take a pain medication like Percocet or another opioid, benzodiazepines like Valium, Ativan, Xanax, these things can make us feel more sleepy during the day. And then, of course, I'm sorry, I'm sort of belaboring the point, but if we're sleeping during the day, it's going to be hard for us to sleep at night. We may be on an activating medication. This could be something like Sudafed or a steroid medication, a steroid anti-inflammatory medication. Those can make it hard to initiate sleep or maintain sleep at night. This is a really important one that I focus on with my trainees, which is that there are certain medications that can cause or worsen an underlying sleep disorder. And antidepressants, common ones being, we call them tricyclic antidepressants. These are things like amitriptyline or nortriptyline. We're not using those so much anymore, but some of the newer antidepressant medications, things, we call these the SSRIs. These are things like Paxil, Zoloft, fluoxetine, Prozac. that class of medications can actually exacerbate primary sleep disorders, restless leg syndrome, and another one I'll talk about in a bit. It's called REM sleep behavior disorder, which actually allows you to act out your dreams. These medications can exacerbate those conditions. And then finally, you could be on a medication that's causing sleep disruptive symptoms. So anyone who might be on an ACE inhibitor, lisinopril, other medications like that, a side effect of that can be cough. That could be waking you up at night. Perhaps you're on a water pill or a diuretic that's causing urination at night. You might be on a medication for a diabetes that's causing you to have low blood sugar and waking you up at night. So this is not an all-inclusive list. There are many other things that could fall into these classes. But what I mean to show you is that medications are important to consider when we're thinking about sleep symptoms. And it's probably after, when I see somebody in clinic, after I get a good history about what's going on, the next thing I do is I look at the medication list to see, is there a medication contributing to these problems? All right, so here are some other things that can contribute to sleep problems as we get older. These are psychosocial and behavioral factors. So substance use is a big one here. And what I like to remind people about in my clinic is that if we're talking about alcohol, for example, our ability to metabolize alcohol changes as we get older. And so what we drank in our 30s and 40s and didn't affect us then might be affecting us now. And I think it's common knowledge that alcohol might make you sleepy. But what I also like to remind my patients of is alcohol can wake you up in the middle of the night. So that's another thing that I look at closely when I'm looking at sleep problems. Other things to think about here are caffeine, same problem with metabolism. And I will share with you that in my 40s, I can no longer drink caffeine after noon. I can't do it. It affects my sleep. So, I encourage people to think about their caffeine consumption as well. And then the other one that works very similar to caffeine is nicotine. So I think about those substances. Also, I think about caregiving. And in fact, this is a big reason that I got to where I am, is that I'm helping care for people who are living at home. They may have some cognitive or functional problems, and now their care partner may also be affected. And so when I'm thinking about helping somebody sleep, I'm also thinking about the care partner. And if I help my patient sleep, I'm also helping the care partner. And so that really drives a lot of what I do. Bereavement can be a common source of sleep issues as we get older. And then here's another place where I'm going to get a little technical, but I hope you'll come along with me. And I want us to think about isolation and poor physical function and how those might affect sleep. So before I get into this picture, I'm going to just talk about the fact that we may have poor sleep habits if we're socially isolated or we're having more difficulty getting out of the house. That can lead to poor sleep habits, right? And I'm getting back to that point of too much sleep during the day, not enough physical activity. But what I'm showing you now, which I think is another really interesting area in which the science is really advancing, is thinking about how exposure to Zeitgebers, which is time cues from the environment, how that can affect our sleep. And so the most common Zeitgeber that we think about is photic, right? It's that light, the exposure to the sun during the day or lack of light in the evening. This actually transmits a signal to our suprachiasmatic nucleus in our brain. That is our central master clock. That keeps us on a schedule. But what's also really interesting is that clock synchronizes with clocks and all of these different organs in our body, the heart, the liver, the kidney, even at the cellular level. We have clocks that are keeping us on a schedule. And this is all coordinated by that master clock in our brain. So exposure to light at the right time is very important for maintaining a normal sleep-wake schedule. But there are also non-photic cues. And these are things like maintaining a normal sleep-wake cycle, a really normal routine, physical activity during the day, social time, meals, right? So meals are a cue to your body to say this is an appropriate time to be awake or not, right? So hopefully when we're sleeping, we're not having those things like light and activity, food intake, and things like that. Okay. So here's the other thing that I want to talk about. I think this is really important. As we get older, nearly every sleep disorder increases in prevalence with age. So when I'm seeing people with sleep problems, I'm really wondering and looking for an underlying disorder that might be causing sleep. And so we're going to talk a little bit about these in the next few slides, but the big ones, the most common ones, obstructive sleep apnea, restless leg syndrome, and insomnia. So obstructive sleep apnea, this definitely increases in prevalence as we get older. It's frequently undiagnosed. And so what is obstructive sleep apnea? So you'll see here on this bottom picture, I'm asking you to think about as you're laying down and sleeping, what might happen to your airway? And you can see that as you're laying down, it's more likely to close off. And so that means now you have a temporary obstruction of the flow of air through your airway to your lungs. And so what does that cause you to do? Well, this is the common scenario, right? Is snoring. That snoring is a sign that you have friction of airflow or that you're actually trying to open up your airway. And I think what's important, and this is another thing I tell trainees about, is this can present differently as we get older. In fact, there tends to be less report of snoring as we get older, or what people usually think of as pauses in breathing. So if you can imagine you're trying to open your airway, it looks for a few seconds like you're not breathing. So those are sort of the common things we look for as sleep doctors, but these are less frequently reported in older people. The thing that tends to be more likely to be reported is those symptoms, maybe more trouble maintaining sleep at night, maybe a lot of sleepiness during the day. And this is a big one, urination at night. So as we get older, we might have to get up to urinate maybe 1 or 2 times a night. But if you're getting up 3 or 4 times a night to urinate at night, I start to be worried about potentially undiagnosed sleep apnea. Yeah, so again, I'm highlighting these because I tell my trainees, I want you to focus on these things. Don't be fooled by a lack of report of snoring, because these are the things that we really need to look for. So here's the next sleep disorder that I want to talk about. This is restless leg syndrome. And this is a clinical diagnosis that we make based on things that we take in the history. So there's this urge to move. And that urge, that discomfort, it can be described in a lot of different ways. It can be a restless sensation, but I'm showing you all the other ways people might experience. Creeping, crawling sensation, itching, throbbing, pulling. So that urge to move. This is worse during inactivity. So for example, perhaps you're watching television in the early evening and you get this urge to move or this creepy crawly sensation. It is relieved by movement, though fleetingly. So people will tell me, I get up, I move, I, flex my legs, I do something like that to relieve the movement, but it's temporary relief. Once you stop moving again, it comes back. And then finally, the fourth criterion for restless leg syndrome is this is worse in the evening. We don't know why, but there tends to be a circadian component to it. Sorry, my mouse is very touchy. So it tends to be worse in the early evening or at the time that you're trying to initiate sleep. And so restless leg syndrome can cause trouble falling asleep because of those sensations, and can also wake you up in the middle of the night because oftentimes it causes more frequent leg movements during sleep. Okay, so the next big one here is insomnia. And so I mentioned this before. This is those symptoms of difficulty initiating sleep, maintaining sleep, or early morning awakening, and that they're associated with a daytime impairment. And this could be described in many different ways: fatigue, low energy, cognitive problems, mood problems, impaired social functioning. And so if we put all of these things together that I've just shown you, it gives you a sense of why sleep problems are so much more common as we get older. And it's because we have all of these things acting in this kind of multifactorial way. So I showed you the changes in sleep, our sleep architecture, our timing, our duration, how that changes as we get older. The fact that we have more medical problems that might be associated with more medication use, those psychosocial and behavioral problems, and then finally, all of these sleep disorders that may be more common as we get older. So I will say, I mean, I look at this as a glass half full kind of person. I usually think that by the time somebody sees me in clinic with a sleep problem, there are probably a lot of things that we could modify here to help sleep. So I look at this as an optimist, and I think there's always something that we can do within this realm to make sleep symptoms better. Okay, so let's talk about what you might want to try to improve your own sleep. So the first thing, the biggest thing, this is definitely where we need to start before we do anything else, is to maintain a very regular sleep-wake rhythm. This means not only going to bed at the same time every night, but getting up at the same time every morning. And so what I often see is if people feel like they don't sleep well, that they try to stay in bed to catch up on sleep. You don't want to do that. You want to get up out of bed the same time every day. The other things that you can do are think about those time cues from the environment. So you want exposure to light during the day. You want physical activity during the day, social activity, and then also meals. These are all cues you can give to your brain to tell you it's time to be awake or it's time for sleep. So sleep hygiene, there's a long list here. Okay, so there are all, and a lot of these things I've touched on already: regular sleep-wake schedule, avoiding caffeine, nicotine, and alcohol, no naps. Okay, so this is a long list. And perhaps you received a list like this from a medical provider when you were talking about your sleep. I want to focus on a couple things. I've already said number one, most important, is very regular sleep-wake schedule. Okay, but I do want to highlight a few things: avoiding caffeine, nicotine, alcohol. Okay, so I've told you about how we metabolize those things and how that changes as we get older. So I want to highlight that one. The other thing is the napping. Okay, so, if I'm being very strict, I say no naps. But if we need a nap, then I ask that it is brief and early. Brief means 30 minutes or less. Early means before 3 o'clock in the afternoon. Now, if you come to me and you say, I'm taking a nap at 3 o'clock and I can't fall asleep, then I'd say, maybe we need to move that time up earlier. But, I understand that for a lot of people, a nap is necessary. And so I just try to put some parameters around that. And then finally, stay active even if you feel tired. The one thing that I see so routinely that I try to address with people is, as I mentioned before, don't stay in bed because you feel like you need to catch up on sleep. Don't say, oh, I didn't sleep well, so I can't go out and do that thing that I was planning. I'm not going to that book club. I'm not going to the theater. I can't do that today. What I ask you to do is maintain your activity, even if you didn't sleep well, because I can guarantee you that next night, your body will be very ready for sleep. If you stay home, you're not active, and you nap, you're just sort of perpetuating the problem. So I put this in here because I get a lot of questions about this too. What about these different supplements? This one is someone in my clinic was taking this, Somnipure. So you can see this has all the things. It's got valerian and chamomile and passion fruit and melatonin. So how do I feel about use of these? Well, the bottom line about these is that there's limited data on usefulness. And so I would say these are unlikely to harm, but we don't have great data to say that they're very helpful. They are safe, but they are unregulated. So that means that the people who make these things are not required to provide data on safety, efficacy, or purity. And so that we don't really know, they're not tested against any of the other medications that you might be using. So in general, this one that I'm showing you, Somnipure, I think it's pretty safe. But I think, you do need to know that these things, these over-the-counter supplements, are not controlled by the FDA. And so you might not necessarily even be getting what these aids say you're getting. For example, I think this one said, what did it say? It said 3 milligrams of melatonin. But nobody's checking them to make sure that it's actually 3 milligrams of melatonin. So that's the bottom line about these supplements. So what about prescription sleeping pills? I'm not sure if you've had an interaction with a healthcare provider around these. I will say, even as a sleep doctor, I don't prescribe these very often. And this is why, because there are a lot of side effects of these medications. So we know that these medications increase risk for falls and things like hip fracture. They can cause cognitive problems. They can impair your ability to drive. And they also have been shown in many different studies to increase risk of death. So these medications, they have a place, but they're really only meant to be used on a temporary basis, okay? So over the order of weeks. And what happens in my position, unfortunately, is I see people who've been taking these medications every night for years. And so obviously I would have hoped that we were never in that position in the first place. But if that's the position that we're in, then I'm going to be thinking about how do we help come off these medications. And so here's one of the ways. This is the first line treatment for insomnia, cognitive behavioral therapy for insomnia. And this is really a behavioral method, so a non-medication method to improve your sleep. And it's because we know that there's this vicious cycle of poor sleep. So when you have negative thoughts about your sleep or negative emotions, that this causes negative behaviors. And so again, this is a non-drug-based method that's really targeted at changing those behaviors, changing those misconceptions that you have about your sleep, and it has a very high success rate. Again, it's the first line therapy before any medication for sleep. So finally, when should you talk to your doctor? So if you are having sleep disturbance that impacts your daytime function, you want to talk to your doctor or your healthcare provider about that. If you're experiencing snoring or pauses in breathing, if you have frequent urination at night, as I mentioned, that's often a sign of undiagnosed sleep apnea. If you have that leg discomfort, right, in the early evening, that urge to move, that restlessness, that is something that can be very easily treated to help your sleep. If you're acting out dreams, so I realize I mentioned this, but I didn't get into it too much. This is a symptom of another sleep disorder that becomes more common as we get older. It's called REM sleep behavior disorder. So usually during REM, we're not able to move our muscles. But what happens with people with this disorder is they're able to move their muscles while they're dreaming. And so they can act out their dreams. And so I mentioned this before to say this can be exacerbated by being on certain antidepressant medications. So this would be another thing that you would want to talk to your healthcare provider about. And then if there is anxiety or mind racing that's impacting sleep, maybe ability to fall asleep, or if you're waking up and you're having trouble getting back to sleep in the middle of the night. Okay, so what would we do? In addition to taking a very good history and physical and reviewing, the medications, you might be told, we think you need a sleep study. So this is the in-lab sleep study. We also call this a polysomnogram. This is the gold standard for objectively evaluating sleep and looking at those sleep disorders like REM sleep behavior disorder or obstructive sleep apnea. And so you can see this is what it requires. So you're usually in a sleep lab. You're hooked up to a lot of different things. And here's the data we get. So we get a lot of really good data about your EEG. This is telling us what different sleep stages you're in when. When are you in REM? When are you in slow wave sleep, etc. And we have eye movements and chin tone to help us with that sleep staging. We're looking at the leg movements. We're looking at how you're breathing, whether you're having those pauses in breathing or snoring that might indicate sleep apnea. We also look at oxygen, we look at heart rhythm. So we get a lot of different data about this. Understandably, people aren't a huge fan of this. It can be sort of burdensome. You're hooked up to a lot of things. You have to sleep in a sleep lab. The other thing that is now really standard of care is to do what's called a home sleep apnea test. So HST, or I call it HSAT, home sleep apnea test, because this is really a test for sleep apnea and not for any other sleep disorders. But you can see this gentleman is wearing what you would be required to wear. So you've got a belt around your chest, you've got a pulse oximeter on your finger for oxygen. You're wearing something in the nose, like a nasal cannula, to get the airflow. And this can be done at home, right? So this is a very nice option. But as I said, it's only for sleep apnea. And it can miss sleep apnea. So if I have a very high suspicion of sleep apnea and this test is negative, then I usually move on to that in-lab study to really make sure there's no sleep apnea. And so I think this is perhaps my last slide before the summary, and then I'm happy to take any questions. As was mentioned in the beginning of the talk, I am a researcher. My research is really all about evaluating sleep using different methods, both self-reported and objective measures, and I like to do them at home because I think that's where we need to go. We need less burdensome measures. We need measures that we can use when people are in their normal environment. And so this is, and I do see the hand, I'll get to you in a second. So this is, we're not currently recruiting for this study, but there is a expansion that we're hoping to get funded. And so if you wanted to send me an email and say, hey, I'm really interested in knowing about what sleep studies you have going on in the future, you can email me either of these ways. So I see a question from Susan. Do you want to go ahead and unmute yourself and ask your question?
Thank you. I'm a little confused on the snoring.
Okay.
You at one point, most recently you said that snoring was a sign of sleep apnea. And then on a slide that was a little bit earlier, under sleep apnea, you had less snoring. And so could you just clarify the snoring factor in sleep apnea? Okay.
Yes, absolutely. So in all comers of all ages, snoring is kind of the classic feature of sleep apnea. Okay. What I'm here to educate people about is, for really a host of different reasons, snoring becomes less common as we get older. And one of the main reasons is because there's a change in the muscle tone of our airway. And so probably what that leads to is, narrowing of the airway or collapsing of the airway without snoring. So you know, what I think is important is that we don't miss sleep apnea because there's no report of snoring.
Yeah.
That actually becomes more common as we get older. So you can have sleep apnea without snoring, but snoring, it tends to be the most common feature of it. Does that clarify?
Absolutely. Thank you.
Sure.
Sorry for the interruption.
Oh, no, I welcome it.
Yeah.
Okay, is it Art? You see a question? Go ahead and unmute yourself.
Dr. Miner, could you unshare screen so we can see the group? Thank you.
Getting back so I
How
can
about
see.
now?
Now I can hear you. Yeah.
Okay, thank you. I have had sleep apnea for over 20 years,
Okay.
25 years, 20. I use a CPAP machine, but I would say in the last 4 to 6 months, instead of getting up once or twice a night, I'm getting up 3, 4 times a night. And now I can't hear you. Oh, hold on 1 second.
Okay. Well, we heard you, but you're muted again. So we heard you say you're muted again, Art. We heard
Okay,
you say
I'm back.
that you know that you have sleep apnea. You've been using a CPAP machine for a
Yes.
long time.
Yes,
And in the last couple months, you're noticing more urinary frequency.
yes, I'm getting up. Yeah,
Yeah,
And-
so I would say, you know, as a sleep doctor, my first line of inquiry would be to make sure your machine's working appropriately.
oh, okay. All right. Do you actually see patients or you're just doing research?
I do both.
Oh, okay.
So I tend to focus on sleep in people with cognitive problems, and that's at the Adler Clinic.
Mhm.
And so that's mostly where I see patients.
Okay. Okay. Thank you.
Okay.
Thank you.
Go ahead. I see, Pat, you have your hand up.
Could you talk more about the restless leg syndrome?
Sure. I didn't see who was asking that question.
Maybe.
Oh, okay. All right, great. So 4 cardinal features. Okay. This sensation of restlessness and urge to move, that discomfort, that tends to be in the legs. It can also be in the arms, but it's mostly in the legs. Okay, so that's number 1, the sensation. It comes on during periods of rest or inactivity. That's number 2. Number 3, it tends to come on or be worse in the evening. And number 4, sorry, it's not always showing because of my background, but number 4 is that it is temporarily relieved by movement. Okay, so if you have all 4 of those features, I will diagnose you with restless leg syndrome. And then I will think about how bad is it? Okay, how severe? Because that sort of allows us to think about the course of action. As a geriatrician, I'm always thinking about what are the behavioral things and the least invasive things we can do. And so I'm thinking about iron storage. I'm thinking about what medications might you be on that are causing it. So, you know, I will look to those things first. I'll try to, you know, replete iron stores if they're low. And then we sort of move on to, can I get rid of a medication, or do we need to use a medication to treat the symptoms? Other questions about restless leg syndrome? And then Bernard, and then we'll get to you, Pat.
Okay.
What's the difference between the restless leg syndrome and cramping at night?
Yeah. So very good question. And oftentimes it can be difficult to distinguish those things. So when people tell me about leg cramps, you know, what I'm trying to figure out, I think probably the next question I will ask is, do you notice that they come on at any particular time, or do they come on at any time? And you might know, because of the restless syndrome criteria that I went through, I'm looking at, are they specifically occurring in the early evening or at night? And so restless leg, cramping can be one of those ways that people experience restless leg syndrome. So if it's at any point during the day, I'm not thinking about restless leg syndrome so much. But if it's mainly occurring in the evening or during sleep, then I'm thinking more about it.
The cramping seems to be related to position or hydration
Mhm.
rather than anything else. And it's
Yeah.
always relieved by just getting out of bed and standing up.
Okay, you find that relieves your cramping.
Oh, yes, if I get it quickly. If I don't get it quickly, cramp may last for 5 or 10 minutes.
Okay. So yeah, I think sometimes people also take supplements, often including magnesium, very safe. And there are some more kind of mineral-based
You know,
supplements out there for cramping that I think can be quite helpful.
Yeah.
And I would say if you're trying that and you're trying hydration and it's not cutting it, then I might think more about whether this might be a symptom of restless leg syndrome.
thank you.
Pat, you want to ask your question?
Yeah, in the newspaper recently, there was a big article on older adults using marijuana
Mm.
and sometimes marijuana for sleep. What has been your experience with marijuana use and sleep?
So yeah, I had to do a deep dive into this literature because so many people were asking me about it.
Yeah.
And what I will say is the literature is not there to support that marijuana helps with sleep. What we know that it helps with is neuropathic pain, so nerve pain. Okay, that's where the evidence is good. Which is not to say that it can't help. It's just that we don't have the evidence to support that it does. The ingredient, so marijuana, it's THC and cannabinoids. Those are sort of the two big, like CBD and THC. Those are the two main ingredients in these different marijuana in various different formulations, right? There are gummies, there are tabs, there are ointments, there are lotions. What I would say, the point of caution here is that the ingredient that helps the neuropathic pain is the THC. And that's also the one that causes cognitive problems. And I don't know about what you all experienced with marijuana back in the 60s and 70s, but today's marijuana is very different from the marijuana of the 60s and 70s. And so again, the caution I would give people is you might not get that same experience that you had back in the day, because they're sort of engineered to have a lot more THC in them. And that causes cognitive problems, falls, other sort of anxiety, all sorts of unpleasant psychiatric symptoms. So a really healthy dose of caution, and also a reminder that we don't have the evidence to prove that it helps with sleep.
Okay, good. Thank you.
Hello, I am wondering about melatonin. I've had 2 docs recommend melatonin.
Yeah. So melatonin is a thing that all of our bodies make. It's released by this part of the brain. It's called the pineal gland. And if you remember back to those first slides I showed you, you have your dim light melatonin onset. That is when your brain starts to release melatonin. When your brain releases melatonin, it's on the order of micrograms, okay? So very small amounts of melatonin. When you get it in the store, it might be 3 milligrams. It might be 10 milligrams. So these are actually very high doses of melatonin. So I think the first thing I tell people is, if you're going to use it, use an appropriate amount. Okay, 3 milligrams should be more than enough. And what I don't want people to do is to keep going up and up and up on the dose, because that's when you start to have side effects from melatonin. The main thing being the thing we commonly see is problems with blood sugar. So that's point number one about melatonin. Point number two is that it has a weak hypnotic effect. Hypnotic meaning inducing hypnosis or helping you to sleep. So, if you have an insomnia disorder with daytime dysfunction, melatonin is not the road for you. Okay. Melatonin is not going to cut it. And I guess, point number three is if it's an occasional thing you use because you have some minor insomnia symptoms, I'm okay with that. It is safe. And I think that's why many healthcare providers recommend it, because they want to do something that they know is okay for your sleep. And they're worried, and they should be, about some of these stronger sleep medications and the side effects of them. So, I think it's safe to use, but you want to keep it at a low dose. And if you're having major sleep problems, it's probably not going to be enough. And that's when you really need to do more, talk to your primary care provider, see a sleep physician. If you really have an insomnia disorder, then we're thinking about things like cognitive behavioral therapy for insomnia.
Thank you.
Gary and Hannah, I see you have a question.
Just on that note about the dosage for melatonin, is it known that when the pineal gland releases melatonin, that it acts through being in the bloodstream, or does it act on a target that's actually closer to the gland? Because that might dramatically affect the concentration compared to what you take orally. Has to go.
Yeah. Okay. No, good question. So there are 2 different melatonin receptors, and those are located in the brain. And so, your question is a good one. If you take 3 milligrams of melatonin, what's the actual concentration in the brain? I would think it would still be a high enough dose, because again, the melatonin you need is on the order of micrograms. And so those receptors actually they do 2 different things. So there's the one that causes that hypnotic effect. That's your melatonin type 1 receptor. So that helps you fall asleep. And then the other one is your circadian timing, your sleep-wake cycle. And so, we didn't get into this too much, but a place where melatonin can be very helpful is that if I think there's a disorder of the timing of sleep, and that we're trying to cue the body to bring that timing back to a normal rhythm, that's a place where melatonin can be very helpful. So 2 different receptors, but again, I think you need very low doses to activate those receptors. Go ahead, Pat.
Yeah. So I was fascinated by sleep apnea and urinary frequency.
Mhm.
I always assumed the urinary frequency was due to the urinary frequency that we have as we get older and bladder control. And I never associated it with sleep apnea.
Most people don't.
I guess. So that was just interesting. And we don't snore as far as we know anyway. But so I don't think that's our issue, but we do get up, 1 or 2 times a night. And often that's when it is difficult to get back to sleep. We have broken the sleep and we had to get up, and the floor is cold, and so we have trouble going back to sleep.
Yes.
So sleep behavior hygiene would say, go back to bed, even if you're awake. Don't get up and read a book or go downstairs. I'm asking because
Okay. Yeah.
sometimes.
So just a couple things I want to clarify.
Okay.
So, 1 to 2 times a night can be a normal part of aging. 3 to 4 times a night, that's when I start to get suspicious. And then, but of course, I'm going to use other things. I'm going to use how you feel during the day. What other symptoms might suggest sleep apnea. And we didn't even get into it, but there are a whole host of things. So, I wouldn't go on the urinary frequency alone. I would look at other things to say, does this look like sleep apnea? And then the sleep hygiene piece, what you want to avoid is being in your bed trying to sleep when your body's not ready for sleep. This sort of sets up this very, negative kind of conditioning. And so, because you start to associate the bed or the environment of your bedroom as a place you can't. So if you're getting up in the middle of the night, I'm going to give you a rule of thumb here, and just recognize that other sleep providers might have different rules or ways to tackle this, sort of analogous to what I told you about the naps. I'm going to tell you what I think about when you can't fall back asleep at night. So my rule of thumb would be, or rules of thumb, I guess I should say, you can get back in bed after 20 minutes. If you can't fall back to sleep, then it's time to try to stop sleeping and do something else. What we don't want you to do is screens, okay? No iPhones, no iPads, no TVs.
No reading books?
Reading is great. Reading is great. I think that, I use a Kindle. So the Kindle the light is appropriate from a Kindle. The light from an iPad, there's a feature you can put on it to block the blue light from the iPad, but the Kindle, I'm not trying to endorse this product, by the way. I'm just saying you want to use a screen that has that's blocking that blue wavelength light. And so, readers, I think, are engineered to do that naturally. You could be in your bed reading. You could get up and go to another room and read. All of those things are okay. The important thing is you're not just sitting or laying there in bed being miserable trying to fall back to sleep. And so once you're reading or you're doing that other quiet activity, maybe it's knitting, maybe it's listening to music, whatever that is, once you feel that you're sleepy again, that's when you try to go back to sleep.
Thank you.
Seems like your partner has a question.
No comments on her sleep. She sleeps beautifully. I'm a power napper. I've been power napping for 30, 40 years. Now it's quite erratic. By that, I mean, if I'm getting groggy in the afternoon, I will lay down on the floor. In 3 minutes, I'm asleep. In 10 minutes, I'm awake and I'm ready to go again. 10, 15 minutes. I've been doing this for years and it's erratic now. So I don't do it all the time, but just, I'm groggy now. I do a power nap. 10, 15 minutes up and re-energized. Comments, problems?
Yeah, I love a power nap.
Yeah.
I wish I could do it, but I
I
can't.
could do it.
10 to 15 minutes sounds great. I mean, the next question I'm always asking people is, what does your sleep look like at night? Do you have trouble falling asleep? Do you have trouble staying asleep? Because if you don't, then I say your napping activity is okay.
It's erratic, but okay. Okay.
Yeah, because the first thing I'm looking at, I want to make sure it doesn't impact your sleep at night. Go ahead, Lori. I see your hand.
I have a question of Rick. Rick, why
Yeah.
do you sleep on the floor?
Because it's right there.
And the fireplace is there.
And you
Fireplace
curl up
is
next
right
to the
there.
fireplace.
Well, but it's also right there in the middle of summer. I said, okay, I don't want to commit to sleeping in the bed. I want to do a nap. Floor is
Got it.
fine. No pillow.
Yes.
Like this. Boom.
So
done.
that's how there are strategies for making your nap shorter. And one of the big ones is
Yeah.
to nap in your bed. Don't nap in a very
Don't
comfortable
nap in your
bed.
bed.
Yeah.
Okay, thank you.
Any other questions? Okay.
Oh, John, I see John.
John?
Yeah, I just joined. I was wondering about, did you discuss sleep apnea?
We did.
John, we'll get you the recording, I promise.
Okay, never mind. Sorry.
Okay, we'll get it to you right away, right away.
And Lori, what I can also do is I can share the PDF version of the slides. The slides have a lot of pictures, so the files are large, but I can share the PDF version, so that's easier to share.
That would be great. If you could send it to Kate, then when people ask for the recording, she can also send the PDF. Thank you.
Problem.
Judith, do you have your hand up?
Yeah, my hand is up. This is weird, but I have the opposite problem. I can't get up in the morning. And it's new, and it's probably related to being alone when I wasn't alone. But the reason I blocked myself was I was having breakfast. Now that's a problem that I suppose other people would be jealous of, but I really don't like it. I don't think it's good. It's not part of the routine, and I need strategies for getting up in the morning besides appointments, which sometimes make it happen.
Yeah. So I think you're touching on something that's really important. I'm glad you're bringing it up because I think we haven't really focused on it, but we can have changes in our lives that really change our sleep routine. And we have to watch out for those things, right? Retirement, caregiving, perhaps there's, loss of a spouse or partner who sort of kept us to a regular schedule and now we don't have one anymore. And I've been surprised. I'll give you an example. I'll see somebody who says, I go to bed at 10 and I can't fall asleep. And that person is going to bed at 10 because that's when the bed partner goes to bed. But that person isn't ready to go to bed at 10. And so, she's trying to take medication so that she can go to bed earlier when her body just wants to go to bed later. So, I think it's important to think about what's dictating those routines. But I'll also say I would go back to what I'm going to do as a sleep physician is I'm going to get an extensive history. When are you going to bed? When are you getting up? Is it an appropriate amount? What does the sleep look like in between? What are you doing during the day? What are your medications like? So there are a lot of things that I would look at to try and understand what's causing that new pattern for you. Okay, thanks. Gary and Hannah, and then Susan.
I just wanted to get back to melatonin for a minute. I know that when it was first popularized or when people were first talking about it, it was mainly for changing, like for traveling, changing time zones. And then I saw some articles which suggested that it was, although it is a mild hypnotic, it wasn't really doing anything for changing the clock. And I'm wondering where that is, because you mentioned that one of the receptors for melatonin is more involved in changing the circadian clock. Right. And are there therapeutic uses, and how would you use it in cases like that, especially if we're planning a trip to the West Coast and we're thinking about doing more traveling, possibly to further locations where there would be a big
so I think there this is probably a less studied area because it's a harder area to study, to think about using melatonin to affect your circadian timing of sleep. But I would say in a clinical sense, we do it. I mean, there are different ways we might use it. People who have shift work and we need to shift their sleep schedule, we'll do that. Certainly if there are concerns about jet lag because of travel, we'll do that. And so really we're sort of doing opposing things. We're thinking about light, but also melatonin. And really this gets very tricky because if you're going east, you're going to do one thing. If you're going west, in other words, if you need an earlier phase, you do one thing. If you need to delay your phase, which is what happens when you go to the West Coast, right? Then you do a different thing. So, delaying your phase when you go to the West Coast, meaning you want to push yourself to a point where you're going to bed later and waking up later, tends to be a little bit easier. And really what that is using light at a time where you would have melatonin onset. Okay, so early evening light. And then opposing that would be early morning melatonin. I don't think you want to get into that because if you use melatonin at the wrong time, you can have the opposite effect. I think the better thing is really thinking about light exposure. So, when you're going to the West Coast, what I recommend is if you can, a nap on the plane, and then you get to, California, wherever you're going, and you get out and you get that light exposure. And that's what's going to delay your phase to help you go to bed later. And I think, by convention, we say that light at the right time delays you about 30 minutes every day. So if you're going east, if you're going to Europe or something like that, what you really want to do is when you get off the plane in Europe, you want to block your exposure to light as much as you can. And so that's hard, right? Because you get out in the airport and it's very bright and there's all this activity going on. But that's what you want to do. You want to try. And so some people use those blue blocking sunglasses that they put on, so I think those are safer, pretty effective ways. The melatonin gets very tricky because of the timing of it. So I don't know that I guess it's easier if you're going east, if you're going to Europe, then you want to do your melatonin at night. You want to block light in the morning, you want to do melatonin at night. Okay, Susan? Oh, you're still muted.
Sorry. Could you just tell me your email address? Again, we switched view and I
Sure,
was
yeah,
writing it
yeah.
down.
So it's
I've got esleep@yale.edu.
That's correct. And then the other one is my first name dot last name at yale.edu.
Ah, okay, great. Thank you.
Welcome.
Well, if there are no more questions, we have kept Dr. Miner for more than an hour. This has been fantastic. You're an excellent presenter. The content was excellent. I think we're all at different levels of struggling with sleep and adjusting. But I really appreciate you coming and sharing your expertise with us. Yeah, a round of applause. And
Yeah.
please let us know if you do get more funding and need more willing older adults.
Wonderful to know. Yeah, thank you so much.
Yeah, this is something that is part of our community activity, being involved, being engaged, and helping the scientists who are helping us. So if there are no final questions, we do have your email. I will encourage people to reach out to you if that's all right with you. And again, thank you for being with us this morning.
All
Thank
right.
you so much.
My pleasure. Nice to see you all.
Yeah, have a good holiday, everybody. If I don't see you, well, hopefully we'll see you at the holiday party.
Good.
But,
Thank you for coming.
Yeah, this has been great. Thank you very much, Dr. Miner.
Bye.
Bye-bye.
Bye, everyone. Take care. Bye-bye.